Good afternoon, good morning, everyone, and thank you for joining us for today's VIA VitaFlow in Association with You webinar. My name is Michelle Harrington. I am a registered dietitian in medical and scientific affairs with VitaFlow North America. We're excited to bring you this educational activity and introduce our speakers. Today's topic is opportunities and hurdles with attaining specialized formula coverage. Support for this presentation was provided by VitaFlow North America, a Nestle Health Science company. The views expressed herein are those of the presenters and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. Please note this presentation is intended for a U.S. audience. Erica Topier is a registered dietitian who practices in the state of Pennsylvania, and the experiences and insights shared by her during this presentation are derived primarily from this state. Please note that policies and practices related to the topics discussed may vary across the U.S. Participants are encouraged to consult local guidelines or to ensure applicability to their circumstances. Elizabeth Tensha is an employee of Palomino, the company administering Formula for Success for VitaFlow USA. Please note, questions will be addressed during and after the presentation. Please submit your text questions into the Q&A pane at any time during the program. You are going to be able to access a PDF of the slides in the chat. CPE is not available for this program. Now I have the pleasure of introducing today's speakers. Erica Topier is a pediatric dietitian with over 10 years of experience who currently works at St. Christopher's Hospital for Children in Philadelphia. She has experience in pediatric nephrology, inherited metabolic disorders, and ketogenic nutrition. She loves helping patients find ways to make challenging diets delicious. Unwilling to give up, her persistent nature has led her to acquire a wealth of knowledge about navigating the coverage landscape for enteral formula access. Elizabeth Tensha is a medical reimbursement specialist. Originally trained as a medical assistant, she returned to school to study medical coding and billing after seeing how frustrated and stressed patients and parents became when faced with denied prior authorizations and claims. Elizabeth has administered the Formula for Success program for 8 years. To date, she has helped over 1,000 people navigate both the complex insurance and the financial challenges of accessing metabolic and renal formulas. With that, I'd like to hand it over to Erica.
Hi, everyone. So we can start with key terms. They're helpful to just kind of get started with what we're talking about today. So diagnosis code, that would be PKU or MSUD, end-stage renal disease. So the ICD-10 code, that's what we're referring to for that. And then the procedure code would be your B code typically, and then the NDC code is the code of the formula. And then prior authorization, typically these specialized formulas require authorization by the insurance prior to approving the claim. So where do you start? You have a patient, they need a prescription for their specialty formula. We start with identifying who the payer is. Is it a government like state program in that case, or is it a commercial insurance or a government insurance like Medicare or Medicaid? All of those will have different aspects to navigate. The various factors that are impacting coverage are that you want to have in place when you're starting a insurance investigation would be having the personal information, so the patient's age, diagnosis, method of feeding, calorie intake, the justification for medical necessity. And then you need to find, so the dietitian is going to have all of that in place. And then the next step will be to find a provider of the formula. Either there's a state program that provides the formula, or you need to find a DME, a durable medical equipment company, to supply the formula. And another layer of that is finding which one is in network or out of network. And then after you've identified a DME, there's the authorization piece of it and the cost piece of it. So even if you get a prior authorization approved, can the patient afford their product? So we'll walk through more details of all of that today. Typically, formula is provided by a durable medical equipment company because, according to insurance, most of the patients that are getting these formulas are enterally fed. So they are getting all of the enteral equipment from one of these DME companies, even though the majority of our specialty formula patients are orally fed. So most insurances want you to go with their in-network DME company. However, a lot of DME companies that are in network with these insurance companies provide things more like wheelchairs or respiratory equipment, and they don't necessarily have a specialty formula to provide. So that's a layer of complexity of navigating these lists that an insurance will provide you with the in-network DMEs that aren't necessarily going to help you at all in this case. So if you get one of those lists and you feel really overwhelmed and you don't have any more knowledge about this than that, a great thing to do is refer the patient to the appropriate assistance program like Formula for Success, because the people that work at these assistance programs have a wealth of knowledge about the DMEs in your specific state and which ones they can get the formula that you need from. So again, I said the information that you need is the patient's insurance information and their letter of medical necessity. A lot of the formula companies have a letter of medical necessity on their website for the product that you're trying to get. They're really well written, and it saves you a lot of time to just use those. And then current clinical notes. So a challenge I sometimes have is that a patient will want a new product or a renewal of their formula, and they haven't seen us in over a year. And so I'm like, you got to come into the clinic and we need notes or we're not going to get anything approved. Every state's different. I am located in Pennsylvania, so I can speak to Pennsylvania, a little bit of Delaware and New Jersey. But I can't say anything about anywhere else. Unfortunately, this country is very varied in their coverage. In Pennsylvania, there used to be a state formula program that provided the formula direct to patients. So some states may have programs like that still. Other states might not have any laws at all in place regarding specialty formulas. Pennsylvania has a really great state law that states that the formula has to be covered and the deductible may not be applied. It has really great verbiage in there. There's a link here on the slide for a website that has all of the states and what their legislature has. So that's a really great reference for what the state laws are in your state regarding specialty formulas. Some states might have WIC coverage for specialty formulas and others don't. I know in Pennsylvania, we can get renal formulas from WIC, but not the metabolic formulas. I don't have an explanation for why. So those are some of the state-specific questions that you can ask that would really help you with navigating what services are available in your state. Again, you have to use an in-network DME typically, and not all insurances have this requirement. Some don't have a preference, but it can be a challenge to find an in-network DME that offers specialty formulas. And again, the assistance departments are really helpful for figuring out which DMEs are going to be able to help you get those products that you need if the initial list that you have doesn't really make any sense. You can always ask if they do provide formula, like say that they provide a nutrition product, but they're telling you that they can't get the one that you want. So then you can ask if they could order it. I know VitaFlow tends to be a little bit more specific. And so if they're offering VitaFlow products, they're probably offering most of them. But you can always ask if it can be ordered. Or drop shipped. Some companies won't stock it, but they might have the ability to drop ship from the manufacturer. That's another term that pops up sometimes. One more thing on that slide. Sometimes, very rarely, the formulas are actually covered under the pharmaceutical benefits. I have one patient of my hundreds of patients that gets their formula from their CVS, paid for by their pharmaceutical benefits. And so CVS owns Quorum, so they can kind of go about ordering the formula through that network, even though it's being paid for by their pharmaceutical benefits. Sometimes insurances require that the patient be tube fed, and that's a really hard barrier to pass when we have an orally fed patient. You can try to appeal, and then there also might be specific state legislature that mandates coverage, even if that's not what the insurance policy is. So there is a possibility for appealing that reason if you get a denial based on being an oral patient. Medicare and Medicaid have their own set of fun things to figure out. So Medicaid, at least in Pennsylvania, we have managed Medicaid plans. There's lots of different ones. We have Keystone and we have Health Partners and Geisinger, and they all have different ways of approving things, which is very confusing because you'd think they'd all be the same. But I tend to encourage my patients to switch their managed Medicaid plan to the one that I know is easiest to work with for specialty formulas. And in the state of Pennsylvania, they're able to make that request to switch their managed Medicaid without too much of an issue. I'm not sure if that's true for all states. Once you've found a DME, they're actually the ones that process the prior authorization request, because in the insurance eyes, they are the provider of the service. So the doctor's office is the prescriber, but the provider that is submitting the claim is actually the DME. So they submit the prior authorization for approval. But they need all of the information that you provide from the provider's office. So the patient's clinical notes, the letters of medical necessity, the script. So you have to work with the DME to make sure that auth gets through. And then if it comes back denied, you can typically request an appeal with an insurance company. Some of them offer a peer-to-peer phone call, and other times they require it to be faxed or mailed in with all of the documentation. It can be helpful to check which billing code was used when it was denied, because sometimes they're really picky and they'll approve one billing code and not another, very arbitrary. But that's one little tidbit that can be helpful. Another thing that I like to do when I have to submit an appeal is I include the GMDI nutrition guidelines for that particular disorder if they're available. Most of my patients have PKU. And so that I just find to be the most comprehensive justification for medical necessity of the metabolic product. And then some patients have a primary insurance and a secondary insurance, and occasionally the primary insurance will deny coverage, but you can get the secondary to approve it. in my experience, you have to submit proof of the claim being processed by the primary insurance to the secondary insurance for them to then go ahead and process it themselves. So the DME has to go through the effort of running the claim through the primary, even though it's been denied, in order to get that secondary to approve it, which can be complicated to get them to actually go to the effort of doing. Medicare typically, historically, has not covered oral formulas, but recently they changed their verbiage to say, rather than having a requirement of being tube fed, and now states that you have to prove medical necessity. I don't have any experience with using this new verbiage to get approval, but Elizabeth told me that she's heard of one success story so far, and we would really encourage you all to let us know if you have success with appealing for Medicare coverage, especially because the inborn error of metabolism patient population is aging, and there's a whole group of patients that will be moving towards being Medicare patients. So that'll be a much more common thing that we'll have to navigate in the next 10 or so years. Another tip is that some insurance companies offer case managers, and they can be really helpful for navigating your insurance, because typically you're just going to get a random person on the phone that doesn't really have any power and just tells you what the policy says and can direct you to the wrong department over and over again, and all of the other fun things that you get to do when you call an insurance company. And so having a case manager to call can be just extremely helpful. Another challenge, maybe you get an approval and then the patient says, well, I still can't afford it because I have a $5,000 deductible and my insurance doesn't cover anything until I've met that and I can't afford it. In Pennsylvania, the verbiage states that the deductible can't be applied to metabolic formulas. And so I've been able to use that to get that overridden for patients. They don't have that same verbiage in New Jersey or Delaware. So I have a couple patients that haven't been able to afford their formula in other states. There is also the NORD assistance program, which is really fantastic. I think it's up to $1,500 a year now. Also encouraging your patients to consider which insurance plan they're choosing, and maybe a higher monthly premium, but a lower deductible would be more affordable for them to access their formula. If the patient gets a new job or moves and they have new insurance, then my process is to have the patient call the DME that they're already with and give them their new insurance. If they can still assist them, then it's a seamless process. If not, then either I'll refer to a DME that I know is easy to work with, or I'll refer to an assistance program like Formula for Success, and they can help us navigate that new insurance and find a new provider for them. Another nice thing, especially specifically with Formula for Success, is that in a situation like that, they will often bridge the patient at least one case of formula while we're trying to navigate that DME switch so that they don't run out of product. A real life example that I have is a patient in Delaware. She had, we tried, I think, probably 13 different in-network DMEs that would not provide the product. Either they were in network, but they didn't provide a formula at all, or they were in network and they only serviced tube fed patients, or they were in network, but they couldn't get the product that she wanted. And she was picky, so we weren't switching products. And so we ended up referring her to Zoe Pharma, and they went above and beyond and negotiated an in-network agreement for a single case with her insurance so that they were able to get in-network rates for providing her formula, even though they're not an in-network insurance. And so that was probably months of going back and forth before we finally had that figured out. And they were really fantastic to work with. I've talked lots about Formula for Success, but they're just so incredibly helpful and caring, and they follow through and they communicate, and they're just really helpful for figuring out when you're stuck. What is the challenge? I have actually had patients that we've been completely stumped, and I've convinced them to switch to a VitaFlow product specifically so that we could work with Formula for Success because of how helpful they are. So they will help you find a supplier if you just don't know what to do. And with that, I will turn it over to Elizabeth.
Well, then thank you so much, Erica, for all those kind words. We do try because we understand how frustrating it is. Um, in a nutshell, Formula for Success is an access support program, and we help people find the DMAs for their formulas or their pharmacies for their formulas, and also help them understand. Often we have to work one-on-one what their challenges are in accessing the formula, because there could be many. Um, and especially when we're working in a community that may enroll in our program over and over again, because every year insurance plans can change, and every year they need support figuring out the new insurance. And we're always happy to be part of that team. Communication is incredibly important because, as you're going to see, the coverage criteria can be accessed by different people in different ways. And when we work together collaboratively is when we can usually figure out the real core issues. So I'm going to start with a slide talking about some of that coverage criteria and where to find information. Erica, can you go to the next slide, please? Oh, oh, there we go. Demystifying coverage, because sometimes it does feel like it's a mystery. I have a little caricature on my computer of Columbo, and he's my idol because his theme he always asks is, just one more question, ma'am, just one more question. And the questions is sometimes how we solve the problem. Um, with coverage, there are different places you could learn about coverage criteria, and I'm going to talk about the 5 major ones today, which is the plan summary description, the plan document, the clinical guidelines, and then additional information from member provider services and the pharmacy or the DME supplier. So next page, please. The summary plan description is the first document that you could get information from, and each type of document can be accessed by a different person on this collaborative team. The summary plan document is only available to the plan member, and they will either get it automatically when their new plan starts, or they could request it from member services or sometimes their HR department. And that is a short, maybe 4 to 6 page long document. It's essentially an outline. It's not very detailed, but it does cover the financial responsibility criteria, such as the deductible, co-insurance if it's a medical benefit, co-payment if it's a pharmacy benefit, out-of-pocket maximum, tiers if applicable, and that can apply to pharmacy or DME benefits. And then the general coverage categories. It usually does not answer the nitty-gritty questions, but it helps patients understand what their cost criteria might be. So next slide, please, Erica. All right, the plan document. Now, this is the one a lot of people don't know about. It goes by different names at different companies. It might be called certificate of coverage or medical policy or something like that. But it's another document only the plan member can request. And they can either call member services, or some plans let you download it from the portal. And it is long. It's usually 50 to 150 pages long. And it's the legal contract between the policyholder and the insurance plan or the payer. And that details what is covered, to what extent, and under what conditions. And just a quick tip, kind of off to the side, a new year is coming for a lot of people. Their plans are renewing or changing in January. And it is possible for your plan name and your member number to remain the same, but the coverage criteria in your plan document to change. So I would recommend every year getting a new copy for that current year and looking through it for any changes that might affect your formula coverage. One of the things we often do, if it's because these are legally written documents, I'm not an attorney, but two heads are better than one. If you want to, if somebody's enrolled in Formula for Success, they want to share that with us, we can go through it together, and we can try to help pick out important parts for you to be aware of. Um, and the plan document is going to outline the diagnosis criteria. Some plans will only cover PKU, some will cover a greater range of inborn errors of metabolism, whether or not it's covered, if it's oral or tube fed, how much of the intake is the percentage of caloric intake. Sometimes there are limitations based on the patient's age. And then there's another section, because you will find those first four things under the covered benefits section of the plan document. But in the exclusion or excluded benefits section, there might be additional information. And sometimes it's confusing because under covered benefits, there's some wording that looks like it might be covered, but when you go to the exclusions, there's some wording that says it's not covered. And that's when we have to start asking the payer more detailed questions. So plan documents, important to have. Erica, next slide, please. Okay, clinical guidelines. Now, these are available on the insurance website, usually under the provider section, because they are written, the clinical guidelines are written for medical professionals. And it describes the medical criteria needed to meet medical necessity per that plan's definition. Your healthcare providers, they know it's medically necessary, but when the plan is using the term medically necessary, they're meaning per that plan document or per these clinical guidelines, does the situation fit that? And if the coverage criteria is not matched or met, it could result in a denial. Important thing to remember is in most cases, if a discrepancy exists between the clinical guidelines and the plan document usually supersedes. So if there's a discrepancy, we're going to have to look at it and talk about it with somebody, either the payer or your HR benefit manager, and try to figure out why that's there and what the coverage actually is. And the clinical guidelines, again, are going to have for your healthcare professional the diagnoses that are covered, whether it's covered for only tube fed or whether it might be covered if it's oral, if it's covered if it's 50% of the caloric intake or no limit for caloric intake, if there are any age limits, and also any growth and nutrition indicators. And that's especially, we see that mostly with the renal formulas, but sometimes that's part of the coverage criteria. Okay, Erica, next slide, please. Okay.
I have something to add that I forgot about.
Yes.
We were saying the nutritional guidelines. Some insurances we've found want the formula to provide a certain percentage of the patient's total needs. That seems to be insurance specific. Some will approve the formula, even if it is a low calorie product, but a DME might not approve providing the formula because the reimbursement is poor, because the insurance is reimbursing based on calories. So it might be approved, but they're only paying for 30 calories rather than 300 calories. So the DME is making less money. So the denial might not actually be from the insurance, but from the DME. So that's another area to navigate occasionally.
That is an additional challenge. I'm hoping we'll have time for me to kind of address that a little bit more detail. Thank you, Erica. So the clinical guidelines, member and provider services, this is the one that, this is the information source most members are familiar with. And it can be accessed by calling the number on the back of the insurance card. There's usually one number for members and one number for providers. And some tips there to always take some notes, keep records of the calls, because you never know when you're going to have to refer back to them. It could be months later. You'll need that information. So you should write down any questions you asked, the answers, the name of the rep. They will give you their first name and their last initial only. The department they're in, because you're likely to get a different answer depending on which department you're talking to. And before you hang up, ask them for a call reference number. Pharmacies usually won't give you one. They'll just give you the name and the date. But most insurance plans will give you a call reference number. If you need to follow up on the call, it makes it much easier to do that. And the information you can get from provider services is pretty much everything we talked about previously, plus some additional bits that are really quite important. The member services can tell you if your plan is self-funded or fully funded, and the origination state of the plan. And those are both important because they affect the way the state mandates may be applied. State mandates, plans that are fully funded must follow state mandates for the state they originate in. If it is self-funded, they do not have to follow the state mandates. They can choose to, but they don't have to. And the origination state comes into play because sometimes the patient lives in Pennsylvania where they have, let's say, wonderful coverage and state mandates, but their plan originates in another state that has no coverage, no state mandate. And that can cause a terrible shock because a patient might expect to have formula coverage and they find out they don't. So that's something that you could find out from member services. They can also tell you if a prior authorization is required, and if it isn't required, if a voluntary predetermination can be done. Sometimes if it's a plan we're a little unsure they're going to actually cover, even though they said they're going to, you could ask for that voluntary predetermination as a little layer of security. It is never a guarantee of payment, but it's better than not having anything at all. Then the member services can also give you a list of suppliers. As Erica mentioned, they're not all viable, but Access Assistant Program should be able to help you, like Formula for Success should be able to help you narrow down that list to the ones that are most likely to have what you need. And member services is asked also who you would call to get a case manager, which Eric also mentioned. Case managers are not available from every plan. But if they are, they're very often, it's a nurse who will understand the medical need, and it can reduce some frustration to have the same person you can call every time instead of calling the main rep line and having to re-explain everything over and over. And it could save time and frustration for a busy family. So that's member provider services. That's number 4. And then Erica, the last slide is for DME and pharmacy. Now, they're part of this team that we work with to try to connect the dots and figure out coverage. And this is where things can get really surprising because the information, this kind of information is not shown at the time a plan is activated. So patients can't really research this very well before they get a plan. And they often don't learn about how these factors affect their ability to access their metabolic formulas or renal formulas until the services are needed and sought. And this is where contracting comes in. And when I use the word contracting here, I'm talking about the contract between the payer or the plan and the DME. And that determines things like in-network versus out-of-network. Are they contracted to provide specific formulas? Or are they contracted only for formulas that are administered by tube? So that's all part of their contract with the plan. And that contract can change at any time. The supplier contract changes. I'm sure Erica's seen times where everything's going great. And then all of a sudden the patient calls up and says, oh my gosh, my supplier says they changed plans and they changed their contract and they can't supply me anymore. And then we start from square one again. And we'll work forward from that point. But that the DMA, that's the contracting I'm talking about. And most DMEs are contracted to bill with a certain code. The codes that are assigned to the formulas are the B codes, but some suppliers can only bill with the S codes. So they might be in network, they might have the access to ordering the formula, but if they're contracted to bill with the S code and the plan wants it billed with the B code, they're not going to be able to service. So it's not shown right up front. It's something we have to explore on a case-by-case basis. Contracting can also happen between the supplier, the DME of the pharmacy, and their distributor. If the distributor doesn't carry the product, they may not be able to order it. We see that more with pharmacy coverage, but it does happen. And some distributors have the contracting that allows them to drop ship straight from the manufacturer, which is great, but that's not always the case. But DMEs and pharmacies can tell you whether or not they're able to do that. And then the last bit of contracting is always a secret. It is the allowed amount that is agreed upon between the payer and the supplier. And and that can affect the patient's end coinsurance amount, because coinsurance is a percentage of the allowed amount. And it's just something to be considered when looking into it. So next slide, please. Okay. I'm going to echo again a really important thing Erica said, and that's to be the new year is coming. For many people, their plan's going to change. To be proactive and tell your formula supplier if you have one, if your plan is going to change. Don't wait for them to reach out for you. They're very busy. They have to re-verify everybody, and they probably won't contact you. It's better to call them. If you can get them a copy of your new card front and back, that will help them as a reference. And ask them to re-verify the coverage, do a new prior auth if necessary, and to confirm that they're still going to be in network for the current year, because all that can change. And then if you do have new insurance for the new year, take it one step further. When those claims process, make sure you review your benefits of explanation to make sure that the claims are being paid the way everybody's expecting them to. And you can look at the numbers. Sometimes the numbers are confusing. A lot of times it's easier to look in that code box on the explanation on the EOB. And there'll be a letter or a number code, and you look someplace else on the bottom of the page, and it might tell you if and even why something was not covered. And so that's important to keep on top of for the new year. Next slide, please.
One other thing I like to have my parents keep on top of is their prior authorization expiration dates.
Yes.
It's really helpful for us to know when an auth is going to need to be renewed. That way we can remind the DME to start that process before the patient needs to refill their formula, so that we don't get in a situation where the patient needs to refill and now we're waiting 2 or more weeks for the insurance to process that auth.
We try to, when we resolve a case, if we have that prior auth expiration date, we try to alert the healthcare provider and the patient, because they also need to make sure they've been seen recently, so that when their prior auth expires, they can get that new prescription, right? That happens too. So thank you. That's a very good point. Next slide. Okay, so now I'm going to talk a little bit about the scary stuff, because nobody likes to get a denial. But I think it's really important to understand what denials are and what they're not, because different denials are handled differently. And if you don't know, it can be really frustrating. You could be working really hard to fix something. I have patients call me all the time, and they're just barking up the wrong tree. So the definitions are the same ones I talked about before. Plan document is really important to have to check that coverage criteria, and the clinical or the medical guidelines. If you get a denial, you're going to need to reference those documents. It's really helpful for the healthcare provider to know the wording that's in there, because if they have to write an appeal with you, they could use the same wording to prove that the criteria is met, and it helps a great deal. Next slide. Okay, so enteral nutrition formulas in your plan. It can be covered, these formulas can be covered under there's different ways they can be covered. And your plan is usually divided into categories: medical coverage, pharmacy coverage, dental, mental, vision, things like that. Obviously, the ones that apply for formula are medical benefits and pharmacy benefits. And I need to compare and contrast them a little bit. Medical benefits, when it looks like your plan is going to cover under medical benefits, then the prior auth and the claim is processed through a DME supplier, a durable medical equipment supplier. And if it's a pharmacy benefit, it's processed through a pharmacy or a specialty pharmacy. If it's a medical benefit, the prior authorization, if it's required, is submitted by the DME. And in contrast, if it's a pharmacy benefit, the prior authorization is often submitted by the healthcare provider. And this is one of those points where communication, where in Formula for Success, we're always trying to connect the dots and make sure everybody knows the answers to these things. That sometimes a DME will say, or a pharmacy will say, oh, we asked for a prior authorization from the healthcare provider, and I emailed the healthcare provider, and I'm like, we didn't get that. So then I get the prior auth request, and I send it to healthcare provider, then I make sure and it's a lot of back and forth, but we got to dot those I's and cross the T's to make sure nothing's lost in transit. So communication's really important there. And then the last major thing is when something is covered under plan's medical benefits, it's subject to the coinsurance, which is a percentage of the allowed amount. And when it's covered under pharmacy benefits, it's subject to a copayment, which is not the same thing. Coinsurance and copayment are different. The copayment is a predetermined set amount, and that is often for pharmacy benefits regulated by tiers. So formula might be covered, but only at a specific tier, which could have a higher copayment than one of the other tiers that's available. So that's two types. So we've got two possible ways something can be denied. It could be denied under medical. It could be denied under pharmacy. There's two other ways. There is a prior authorization denial, which is a pre-service denial. It's when the insurance plan says, oh, you have to get a prior auth is submitted, and it's denied before any service is rendered. In contrast, a claim denial is post-service. So everybody thinks it's covered, the claim is submitted, and then they get a notice saying that it's not covered. And they both have to be addressed differently. For the prior authorization denial, usually the plan member and the healthcare provider are notified, often by mail. For the claim denial, the supplier is the one who's notified. So the patient might not get a notice saying there's been a denial, and the DME may resubmit that, especially if they think they made an error. They might resubmit that. And the patient might not get a letter from the plan, but it will show up most likely in their explanation of benefits box, which is another reason why it's important to check those. Next, okay. I'm going to talk a little bit about what's not a denial, because only denials can be appealed, and a lot of times people use the term, it's not, I can't get it, it's a denial. That's not the technical term, and I'm only being nitpicky about it because the insurance company is going to do that. They're going to be nitpicky. If it's not a denial, there may not be an appeals process for it. Things that are not a denial are high deductibles, high coinsurance, a limited supplier network, which is something Erica mentioned before, a lower reimbursement rate, supplier contract change, I talked about that just before, or supply disruption. So these are all challenges, and they're all upsetting challenges, and we may be able to help you find workarounds for them, but they are not denials. So I'm going to talk for a little bit about appeals specifically for true denials, which is the next page. Awesome. So I'm not going to go into huge detail. Just I'm going to give some starter information about the denials because there's this critical point, and it's what you do when you receive a denial notice in the mail. And the first thing is it's disparaging. You might be like, oh, I got to get the kids to practice, and I'll just put it on my desk, and I'll think about it on the weekend. And please don't do that. Read it right away. Read all the pages until you get to the part that's in a language you don't understand. Read all the pages in the beginning. It's going to give you, it should give you the reason for the denial, the clinical guideline or policy reference used to make the decision, and the directions for appealing with a timeline. A lot of times there's a timeline like 30 to 90 days where you could appeal, and if you wait too long, you miss your chance to appeal. And appeals can be upsetting because they usually mean extra work, but they are an opportunity to overturn the denial. So you have a chance. Another reason to read that right away is if a peer-to-peer is allowed, the window to set one up for your healthcare provider to set up a peer-to-peer, that's when the doctor at your practice and the doctor at the plan talk to each other. They're both very busy. It's a very short window to set that up, sometimes as little as 24 to 72 business hours. So if you get a denial, let your healthcare provider know immediately. So if they want to try a peer-to-peer, they have a little time to try to get that done in. And then save all the pages. Save all the pages for your records. Even if you appeal and it is denied, you will have that denial on hand because some financial assistance programs that might be available through the state or through a charitable organization or a nonprofit organization, they might want to see proof that it's not covered, and that denial is going to be your proof. So don't throw it out. The second thing that you can do once you receive a denial is figure out if it's a prior auth or a claim denial, because that's going to help you determine who should take lead in the appeal. If it's a prior authorization denial, the member usually receives notice from the plan. The healthcare provider and the supplier may work on the appeal together. So they might connect, and the goal is to show that the requested formula meets the plan's criteria for medical necessity so that supplier can process the order. So usually the healthcare provider or the DME might reach out to the healthcare provider for more documentation. So they kind of will work on that together. If a prior auth is denied because there's something missing or because there was an error, the supplier, the DME, might try to correct that on their own and just resubmit it. So that's one type. And the other type is the claim denial, and that is handled differently. Most often the plan shows the claim denial on the explanation of benefits. A separate notice might not be sent. And if anything looks amiss on your EOB, call the supplier for the next steps. Very often, the supplier might resubmit the claim again if they think it was an error on their part, or fill in any missing documentation they didn't include. But the supplier may not inform the member. We've had a number of times where members will say, "Oh, this hasn't been covered for 4 months," because that whole time the supplier might have been able to rectify it on their own. So if the supplier can't fix a claim denial on their own, then that responsibility is going to fall to the member, and probably with the help of the healthcare provider to try to get that overturned. So identifying who was going to take the lead in the appeal is going to name the players in that appeal. Uh, and if you have any doubt, just reach out and ask anybody involved to tell you. And the last tip is to request those reference materials. If you don't already have them, do get a copy of the plan document and the clinical guidelines. And if you're enrolled in Formula for Success, we can review those documents with you and try to help pick out the wording that would be helpful for your healthcare provider to see before assisting with the appeal. And we welcome you to call with any questions. We're always happy to help.
I thought of one other tip. If all of these avenues that we've talked about have failed, I have had success with the patient appealing to their employer if they have employer-based insurance to get the employer to request coverage. Since the employer is the subscriber, I'm not sure if that's the correct term, of the plan, they can actually tell the insurance company that they want coverage.
That's
So that's
true.
another avenue that you can try if all
That's
else.
true. It's called a benefit exception, and it's available to people with self-funded plans. The healthcare provider does have some leeway and some influence over if an exception could be made. They might make it, they tend to make it more for a child. They tend to make it for a certain limit, a limited amount of time. But it is every pebble, look under every pebble because it matters. Getting coverage for formula for 3 years is better than not getting it at all. So always explore those the HR if it's something they can help you with. The fully funded plans, HR doesn't have, your employer may not have the same leeway with those. But hopefully a state mandate might help if your state has one. That's a really good point. Thank you, Erica.
Thank you, Elizabeth.
Erica and Elizabeth, thank you for such an informative presentation. At this time, I would like to encourage the audience to put in questions in the Q&A pane. And while we were presenting, we got a question from Jackie, which Erica did answer, but I'd like to share it just for the sake of the audience. So Jackie was saying she has a baby on dialysis. He just turned 1, but is having issues with the texture of foods. So he needs to remain on the renal formula, but WIC is denying, and appeal was denied due to age. Any suggestions? Erica, could I have you share what you told Jackie?
Yeah. I said, could you switch to a pediatric product? Maybe they denied due to age because you were trying to get an infant product approved. And then my other question was it WIC that denied the appeal? And if so, have you tried insurance rather than WIC?
Yeah, so if you could give us more info, Jackie, maybe we can help. In the meantime, another question. Erica, are you hesitant to change formulas because you are concerned that this could cause problems with coverage? So you have a kid who's covered, everything's great, but the family's interested in changing, let's say, a metabolic formula.
Thank you for asking that. I forgot. I always want my patients to be on the product that they are going to actually consume. So I never tell them no. I'm always willing to try. So if they are with a DME and they're on a product and they want to switch, then we'll send the order to their DME and see if they can get it approved. If they can't, I will always tell them that there's the possibility that we might not be able to get that product due to the DME refusing to provide it or the insurance refusing to cover it, but I'm always willing to try.
Great. Jackie came back. Both denied and appeal was denied. We'll look into a pediatric renal product. Thanks. Jackie, VitaFlow has a pediatric renal product, and maybe you want to tap into Elizabeth to get some help there. Another question. Um, so, Erica, with the recent formula shortages, a number of dietitians are trying to get patients accustomed to new formulas just so they have a taste for it. Do you have problems getting like formulas from different companies or many different forms covered for one patient?
Can you ask me that question again? Like, what do I have difficulty with what?
Multiple forms of product. So back in the day, we might do like, let's just say PKU Spear 3 times a day. But now the trend is more, we're trying, let's say, a spoonable, a ready to drink, and then a powder. That's the desire of the family. Are
Yeah.
you able to get that kind of combo, or is that more challenging to get covered?
Um, I think it depends on the insurance. Sometimes those products actually use the same B code. And if they use the same B code, sometimes it's not challenging because the DME will just bill for like X number of units. And so the patient might be getting 2 different products, but as far as the insurance is processing, they're just processing more total units of the same B code. It can be more challenging if there are different codes and the insurance policy covers say B4157 but not B4155. So some of the like supplementary products are a B4155 code and those ones can be trickier to get covered. So I sometimes have challenges with that, but I always try.
Yeah.
Elizabeth, do you have any other things to add about
I,
that?
not specifically about that, but I did want to, Eric actually reminded me about something that I wanted to mention because it is important. Pennsylvania does have an exceptionally well-worded um, state mandate that covers a lot of the loopholes that we see in other states. And she didn't remind me that in Pennsylvania, that the origination, if there's wording that says that the state mandate follows the Pennsylvania state mandate, regardless of origination state. So earlier I said Pennsylvania because I was thinking about her, but it's actually that wasn't a good example because of that.
But that's okay. I mainly shared it so that everybody knows that their state laws are like hyper specific. And if you want to get involved in legislature, you can actually, advocate for better verbiage in your state. So Pennsylvania has a really well written law, and Delaware does not. So I have
What's the
experience.
precedence? Yeah.
And some states are, it's more limited what's covered, or they're only covered to a certain age as far as the mandate.
Another thing that I forgot to mention about state specific is that in Pennsylvania, at least PKU is considered a disability that allows for Medicaid based on disability approval. So some states have the opportunity to be approved for Medicaid based on disability rather than based on income. And so that might be another avenue for insurance coverage for you, depending on your state laws.
Fascinating.
We have another question. All 3 of our state Medicaid plans have stated denying specific formulas, saying they are not allowed on the contract between the DME and the insurance. We'll cover the PKU formula, but not the infant formula or the toddler formula. That's interesting.
Yeah.
I'm surprised about the infant versus toddler formula.
Almost
I
think
was
it
going
would
to
be
say that
reversed, right?
I was going to say that. Yeah, I was going to
Yeah.
say it might have more to do with the calories or something, but infant formulas are higher in calories typically. Elizabeth, I am going to default to you on that.
Well, I think if it's a state plan, and I don't know what state it is, but if it's a state plan, that is one time where I'd pick up the phone and ask for a case manager to help you navigate that problem. Um, there may be a different avenue. And if it's been denied through all three MCOs. And what was the wording for the question? It was denied how?
It says that they are not allowed in the contract between the DME and the
DME.
insurance. So that it
Okay.
says that they're covering the toddler formula, but not the infant formula. It seems a very
So
specific contract agreement.
that's and so, that's what I was talking about contracting before. Sometimes that does exist, and I would ask a case manager to see if they could explore that further. I was wondering if maybe it might be in a state where they might cover it if the patient purchases it and then they reimburse the patient. But that's kind of tricky to do. I would start with a case manager first for a
I have
little.
another thought too. Considering that they are covering the toddler formula and not the infant formula, and you're specifically talking about Medicaid, I'm wondering if their assumption is that WIC is supposed to be providing the infant formula.
That could be true if
So
it's
they are
underage
not
5.
offering coverage of the infant formula under the Medicaid because they're assuming that if you have Medicaid, you're WIC eligible and should be getting that infant formula from WIC.
Right. And there are some states where WIC will only allow you to have one formula. So if you need a regular infant formula and a specialty infant formula, it sometimes can take some extra steps to get the point across that you need both and see if that might be allowed. So I don't know, the question didn't say if they're already getting another formula too through WIC.
Let me ask you this. This is exactly the kind of process stuff that I find so complicated. So
Oh,
should Charlotte help her patient by going to WIC and asking, or should she ask Medicaid, should I be asking WIC? Where are the lines?
I think you could go either direction,
Okay.
but I I think it would just depend on which one I thought was the path of least resistance. So
Yeah.
is it easier to get a knowledgeable person at WIC or is it easier to get a knowledgeable person at
Uh,
Medicaid? And then I would just call that
oh,
avenue
I
to
would
save myself.
I would do both, and because you might get different answers. I mean, if the answer matches, I would feel more confident that you're getting correct information. Um, Usually, if we're assisting with that, um, folks at WIC they usually prefer to talk directly to the patient or the healthcare provider. So we're kind of limited. We call up, we find out which is the correct department that the family needs to contact
mm,
so that they don't waste a lot of time getting passed around um, to different places because sometimes it takes a few phone calls to get the right phone number. And we put them directly in contact with the dietitian there. And they could usually say if it's on the WIC formulary for that state most of the time.
Another thing you can do it's more effective if a family does it, but you can have a family contact their state rep
Yeah.
for either assistance or advocacy on approval.
Yes. And if it's another resource, if you have a commercial plan, is your state insurance commissioner. They
Yeah.
don't they don't deal with the government insurances or TRICARE or anything like that. But if it's a commercial plan, they can help clear up some of the legal considerations. I I had a family come in years ago and I felt so bad. They had taken their case all the way to court
wow.
and they could have saved a lot of time and money by calling their state insurance commissioner. And I felt so bad for them. But we eventually were able to help them. So that's the good thing. But they went through an awful lot to get to that point, a lot of wheel spinning. It's just, we want to help people avoid that whenever possible.
Yeah. We are at time. So I just want to again thank Elizabeth and Erica and the audience for your participation. We hope you enjoyed the presentation and that you find it helpful for your practice. This is our last webinar for the year for VitaFlow North America. We so loved having everyone join us throughout the year for our educational events. Look for us in 2025. We're going to be rolling out new content. We'd really appreciate it if you complete the post-event survey. One of the questions is, what would you like to hear more about? So definitely looking for new topics. We love to take requests. So with that, I'd just like to say enjoy the day, enjoy the holiday season, and I hope everyone has a very healthy and happy new year. Thank you.
Thank you.
Thank you.